sessions. In the upcoming sessions, we shall delve in our various facets of medicine and gastroenterology and newer advances with some of the most celebrated visionaries in their fields. So let us begin our today's first session.
To present our first session, we have with us Dr. Raju Mahule, who is the young and first gastroenterologist from Gondia with us here today. He will be presenting on basics of IBD, when to suspect natural history medication. The chairpersons for the session are Dr. Saurabh Rokde, Dr. Raja Bafna, Dr. Vivek Bhalerao, and Dr. Deepti Chand. We request our chairpersons to kindly occupy the seat on the dais. Thank you.
Hello, good morning everyone, respected seniors and colleagues. Thank you very much to Midas and his team to give opportunity on this great platform to present one case presentation of the IBD and basics management of the IBD. So I would like to start my case presentation. So this 32-year-old male patient presented with to the gastro-OPD with loose motions 5 to 7 episodes per day, mucus and blood mixed with stools, crampy lower abdominal pain since last 1.5 months. So on investigations, there was CBC show HB was 14.6, leukocytosis that is 14,000 count, platelets was 2.2 lakhs, LFT and KFT was normal. There was no any electrolyte imbalance. INR was normal. USG abdomen so normal. There is no any abnormalities. Lipase was normal. ESR was 17 and CRP was 0.42. So we can suspect this may be the infective colitis or it may be ulcerative colitis. So on colonoscopy there was a diffuse loss of vascularity, granularity and friability with few superficial ulcer and mucosal bleeding on minimal scope manipulation in rectum, in sigmoid colon and descending colon. So impression was the left-sided colitis and it was Mayo score was 3, that is severe, and ulcerative colitis endoscopic index was 7. So we have taken the biopsy from the colonic endoscopy, and there was this show there is a cryptastasis, crypt distortion, and there is a loss of the crypt architectural. That is, it is a confirmed case of the ulcerative colitis. So the final diagnosis was ulcerative colitis, that is a left-sided colitis because involvement of the rectum, descending colon and left side of colon. So what is the natural history of the disease in the ulcerative colitis? If patient present to you with a mucoid stool and crampy abdominal pain, low-grade fever, so in natural history in this case, 50% of the patient can present with the proctitis, that is mild disease, left-sided colitis 30% of the patients, and 20% patient presented with the pancolitis, that is extensive colitis. It is defined by the macroscopic examination on the colonoscopy only. So we have calculated the scores, that is Mayo scores, how it was. It was a severe, depend on the frequency of the motions, rectal bleedings and endoscopic finding and global medical assessment in the form of the physical well-being of the patients and physical examination and performance activity. Based on that we calculate the Mayo score, that is 11, that is severe. So what is the management in this case? If the patient presented to you this such type of bleeding, lower abdominal pain and low grade fever, so how it is approached to the patients? So in the patient with mild disease, moderate disease and severe disease, mild to moderate disease we have the step up approach, and severe acute severe ulcerative colitis top down approach. So mild disease we can start aminosalicylic acid, budesonides, topical or oral or in the combination. Then corticosteroids for the moderate disease, and for the severe disease we can have the options, that is anti-TNF, cyclosporine, and if the patient not responding to the biological agent and corticosteroid, then another option is colectomy or anti-integrin patient with Crohn's disease. So if the patient came to you ulcerative colitis, diagnosed on the biopsy, endoscopic finding, clinical pictures, and you started the treatment. So we have active mild to moderate ulcerative colitis, patient started on the oral mesalamine and topical mesalamine. Remission, then continue the oral mesalamine or topical mesalamine. If the patient have partial response or no response, shift to the steroid, and if on the steroid or oral steroid or systemic steroid, topical steroid, systemic steroid. So treatment offer in this case, in our case, this was severe disease, moderate to severe disease, that is Mayo score was 11. It was started on the oral steroid, that is methylprednisolone, 32 milligram, taper over 3 months, mesalamine 1.2 gram TDS initially, then topical mesalamine pentazole suppository 1 gram BD. According to guidelines, more than 3 grams per day was significantly more effective than the 2 gram per day for induction of the remission in mild to moderate ulcerative colitis. For the maintenance of remission, standard dose 2 to 3 grams per day, superior to low dose but not inferior to the high dose. Response and maintenance of the remissions. It is very important to see the response. How to check the response of the patient on the treatment with mesalamine or steroid. Response means the clinical and endoscopic improvement, a decreased activity of the index more than 30 plus decrease in rectal inflammations, that is decrease the Mayo score more than 3. This is the response. And remission, complete resolution of the symptom and endoscopy and mucosal healing and clinical practice. How you can define the remission? Stool frequency less than 3 and there is no blood in the stool and there is no urgency. So he was maintaining one remission, oral mesalamine, they decreased the dose 1.2 gram BD, topical mesalamine, suppository 1 gram HS. Now the first relapse. What is the relapse? If the patient flare of the symptom with established UC who have clinical remission, either spontaneous or after medical treatment, that is called relapse. There is type of relapse, is frequent or infrequent relapse. Infrequent relapse less than 1 per year, frequent relapse more than 1 or 2 per year, that is called frequent relapse. In Jan 2019, 7 months later after a diagnosis and after the started our treatment, he again presented with the loose motion 10 to 12 episodes per day associated with the mucus and blood, and again with lower abdominal pain for the 20 days. What is the cause of the relapse? If the patient diagnosed ulcerative colitis and presented to you, you should think what are the causes of the relapse. It may be infection, it may be treatment adherence, means the patient not taking the proper treatment or not optimized, we have not optimized the dose, or psychological stress, pregnancy, NSAIDs, these are the causes of the relapse of the patient. So now, whenever the relapse, consider the adherence, use of the enema suppository or not, dose optimization. Have you made the most of what you have got? Dose optimization, topical therapy, enema suppository not given to the patient. 5-SA in case of the flare, increase the dose of the 5-SA. Azathioprine 2 to 2.5 milligram per kg require 3 months for the action to manifest, and steroid tapering off. Too fast tapering of the steroid can patient may relapse. So investigation performed in this case in the first relapse, sigmoidoscopy. So ulcerative colitis presents show Mayo grade 3 proper sigmoiditis, and there was a hemoglobin also down, that is 9.2. Count was raised, leukocytosis, platelets were 2 lakhs, and ESR 42 and CRP 36. It means severe, acute on severe ulcerative colitis. So what are the severity? How to diagnose this, it is severe or not? Depend on the Trula-Wetz criteria. The presence of more than 6 bloody stool per day along with any of the following, that is tachycardia, fever, HB less than 10.5, ESR more than 30 and CRP more than 30, that is acute flare on a chronic disease. Many may be presented with the first time, that is 1/3 of the patient, that is 20% of the patient can present acute severe ulcerative colitis. So in our patient, fulfill the criteria for the acute severe ulcerative colitis. What is the next? What next? Treatment offered for this acute severe ulcerative colitis, hydrocortisone, 100 milligram, 6 hourly. Patient responded and was switched to oral prednisolone. So what is the management of the acute severe ulcerative colitis? Is the algorithm for the management of the acute ulcerative colitis. Acute severe ulcerative colitis, stool frequency more than 6, blood in the stool, temperature, that is fever, pulse rate more than 90, hemoglobin less than 10.5 and ESR more than 3. Admit in the gastroenterology ward. At the admission, take the proper clinical history, causes of the relapse or causes of the flare, causes of this acute severe ulcerative colitis. Temperature first maintained. Investigation to be sent, complete hemogram, electrolytes and X-ray abdomen to rule out any perforation. X-ray abdomen to rule out any toxic megacolon that is diameter more than 5.5 centimeter or any perforation. We have to send hemoglobin, viral markers, serum cholesterol level, and cytomegalovirus serology for the diagnosis of the acute severe ulcerative colitis. And treatment offered in this phase: hydrocortisone, IV fluid, maintain the hydration, and avoid the drugs, iron tablets, NSAIDs, loperamide, and anticholinergic drug. So, after 3 days of the treatment, we assess clinical assessment, how is the progression of the disease or regression of the disease, how is the treatment response. In clinical assessment, investigation, see daily, that is CRP, ESR, and hemoglobins. If hemoglobin less than 10.5, need blood transfusion. So after 3 days, Travis criterion, stool frequency more than 8. After the steroid therapy of the 3 days, our stool frequency is still more than 3 plus CRP more than 45 milligram per deciliter, that is patient is not responding to the steroid. So in this case, we have to start infliximab 5 milligram per kg IV or cyclosporine. If failure, the patient can pass for the surgery. So any point of after the diagnosis of the acute severe ulcerative colitis, if the patient has abdominal sign, that is signs of the peritonitis, you may not confuse with the signs of peritonitis, because the patient on the steroid therapy, the signs of peritonitis can be masked. So it is very important to diagnose the patient having perforation or not by the CT scan or X-ray abdomen, chest X-ray. If the patient having the heart rate more than 90 or systolic blood pressure less than 100 milligram mercury or active bleeding, then directly shift to the colorectal surgery on an urgent basis. So, what is the option? What are the options of the patient who are not responding to the steroid? Acute severe ulcerative colitis not responded to the steroid. There is option of the infliximab, that is anti-TNF, adalimumab, vedolizumab, ustekinumab, and cyclosporine. And a patient with poor, then can we shift to the tofacitinib. Dose of tofacitinib 10 milligram TDS for the 3 days in acute severe ulcerative colitis and 10 milligram BD for the 2 months. Then remission, on remission 5 milligram BD for the lifetime. For the maintenance of the remission, oral steroid were tapered off. In this case, azathioprine was started. Why azathioprine started, I will later. 50 mg OZ and increased to 100 mg OD or oral mesalamine, that's mesocol 1.2 gram BD. Patient required one oral and one IV steroid therapy in the course of 1 year. Hence, adding azathioprine was considered. So, what is the indication? What are the indication of the ulcerative colitis for the adding azathioprine? Steroid dependence. What is steroid dependence? The patient, after 3 months of the therapy, we cannot stop the steroid or taper off the steroid, that is, and recurrence of the symptom after the 12 week of the stopping of the steroid, that is called steroid dependence. What is steroid resistance? If the patient not responding or patient is active disease in spite of the 7 to 10 days of the IV steroid, that is called steroid resistance. And steroid refractory, same. The patient not responding to the steroid 4 weeks of the therapy, oral therapy, that is called steroid refractory. 2 course of the oral steroid in a year and 1 course of the IV steroid in a year. This is indication for the azathioprine in UC, along with biological to increase the remission rate, along with the cyclosporine for maintenance of the disease. Second relapse in April 2021, patient again presented with the loose motion, 6 to 8 episodes per day, so with the mucus and the blood. Same complaint for the 1 month. He was on maintenance with the mesalamine and azathioprine. His sigmoidoscopy saw Mayo grade 2 proctosigmoiditis. Treatment offered to this patient, tofacitinib. This time patient was considered for the tofacitinib as a failed to maintain the remission on azathioprine and conventional therapy. Tofacitinib was started 10 mg BD for the 8 week. Patient responded well, and patient continued remission on maintenance dose of the tofacitinib 5 mg BD and mesalamine. According to ECO guideline, Recommend treatment with tofacitinib induced remission patient with moderate to severe ulcerative colitis who have inadequate response to the or intolerance to the conventional therapy, then added tofacitinib. So position of the tofacitinib in ulcerative colitis, moderate to severe ulcerative colitis in a patient with biological naive or patient with the previous failure of the TNF, that is indication for the tofacitinib. 10 milligrams BD for the 8 week. Maintenance of the remission in moderate to severe ulcerative colitis. 5 milligrams twice a day per day. Loss of response in 10 milligrams twice a day. Acute severe ulcerative colitis, first line therapy. Dose amount in acute severe ulcerative colitis 15 milligrams twice a day for 3 days, followed by 10 milligrams twice a day. Discontinue of response if the discontinued tofacitinib if the response of the not achieved by the 16 week of the 10 milligram BD dose. So game changer tofacitinib, oral drug. Why it is used? Oral drug, it is short half-life, no immunogenicity, no development of antibodies against the tofacitinib. Response in previous anti-TNF exposed, extraintestinal manifestation, comparable efficacy, rapid onset of action, and acute ulcerative colitis. So the complications, thromboembolism, infection, and causes use in elderly and comorbid patient and in pregnancy. So treatment monitoring, how to monitor the treatment on patient on the tofacitinib therapy. Cardiovascular risk, history of the venous thromboembolism should be ruled out, herpes zoster and pregnancy should be ruled out first. Test CBC, RFT, LFT, fasting lipid profile. Check the complete blood counts. If hemoglobin less than 8 or drop more than 2, then stop the this tofacitinib. Check the LFT and creatinine. If the patient has CKD or CLD with creatinine clearance less than 49, should be stopped tofacitinib, and CTP more than 2, half the dose. Check the serum lipid profile by the 8 weeks and treat according to the hyperlipidemia recommendation. Complication of the therapy, patient remain on the remission on tofacitinib for the 5 mg BD and mesalamine, maintaining on remission. However, after 1 year, in April 2022, present with fever, low grade evening rise, and with cough and loss of appetite for the 20 days. So what is the next step? What we have done investigation for the tuberculosis. We suspected the patient can have the tuberculosis. The hemoglobin was 10.7, TLC was 5000, LFT was normal, CRP was 100, and ESR was 80, and quantiferon gold positive in this case. The chest X-ray left side proliferation tapping done, and there was a ADA was 42. This is significant for the diagnosis of the tuberculosis. So what is recommendation for the patient on biological treatment? Means this patient developed the tuberculosis after biological therapy. So what are the recommendations for this patient? The stringent latent tuberculosis screening, that is tuberculosis screen test, IGRA, CCT abdomen, CCT chest. A latent tuberculosis diagnosed on the basis of the CT, that is calcified granuloma more than 5 mm, calcification of pleural thickening, upper lobe fibronodal disease. So diagnose the latent tuberculosis. Treatment offered for the latent tuberculosis: isoniazid 9 months, isoniazid rifampicin therapy, and rifampicin for the 4 months. So tofacitinib induced tuberculosis, 12% had diagnosed and started under ATT. Mesalamine was continued. Patient was on remission on maintenance dose on tofa. So what are the next steps? So patient with this tofacitinib developed tuberculosis, started ATT. Should we continue tofacitinib along with ATT or discontinue? This is the question for us. Now the fourth case scenario, that is latent tuberculosis, at least 3 weeks after commencing of the treatment latent tuberculosis, anti-TNF to be started. In urgent cases, is simultaneously initiation of the latent tuberculosis treatment and anti-TNF therapy can be considered. If the active tuberculosis diagnosed during the anti-TNF therapy, anti-therapy should be withhold for the 3 months, then again started after the resolution of the symptom of the patient. Anti-TNF therapy may be started after 2 months of anti-TNF therapy. The patient demonstrates favorable response. So these are the management of the TB after biological therapy. In our case, we continued the tofacitinib with the ATT after 3 months, July 2022. ATT, he had HRE regimen, asymptomatic rise SGOT and SGPT, 5-fold. So hence was presumed to be the ATT-induced tuberculosis, ATT-induced hepatitis, for which patient's ATT was modified to the levofloxacin, ethambutol, streptomycin therapy. He was followed up for the 2 week, another 2 week after modified ATT. Even after the modified AT, his LFT didn't improve. So we thought that the patient, they will TOPA-induced hepatitis was, we thought. And it was a culprit, and his stop of the topacenib for the 4 days. After 4 days, LFT was normal. So later patient was resumed on standard ATD therapy. After stopping the topacenib therapy, the patient was maintained the remission on mesalamine and topa, it was discontinued. So what is third relapse? The patient maintained the remission with mesalamine for 2 years. It was okay. Now in July 2024, again, he again presented with the loose motion 4 to 5 episodes per day, also with the mucus and blood, with crampy abdominal pain, also with the urgency and tenesmus and fever for the 10 days. So what we can suspect? On colonoscopic sigmoidoscopy, there is a large irregular geographical punch-out ulcers. So we have taken the biopsy for the CME colitis and detect the CME 74 lakh. So this was positive. How to detect the CME in the patient with ulcerative colitis? CME infection and CME disease, serology, CME antigenemia and CME PCR, and inclusion body 1 histopathology and positive for the ISC, immunohistochemistry, and positive for the CME PCR. So what are the cutoff value for the diagnosis of the CME colitis in the patient with ulcerative colitis? So cutoff value, what are the risk factor? Severe disease, steroid, what are risk factor CME colitis? Steroid, severe disease, steroid resistant patient, immunosuppression have started, steroid immunomodulator, cyclosporine, advanced age. These are the extensive disease, these are the risk factor for the CME colitis. So what are the cutoff value? One, the cutoff value we have to start the treatment. Patient with inactive ulcerative colitis, mild to moderate ulcerative colitis, no immunosuppressants used, no testing of the cytomegalovirus recommended. In severe ulcerative colitis, immunosuppressants used, steroid refractoriness.
Dr. Mahule.
Yes, sir. Or endoscopy, we have to
Dr.
check
Mahule.
endoscopy.
Make it faster.
Your time is over.
In our case, patient was given ganciclovir for the 3 days and shifted to the oral valganciclovir for the 900 mg BD for the rest of life, and 2 to 3 weeks, and this stopped. He responded well to treatment and diagnosed and discharged on our follow-up. So May 2018, initial diagnosis was UC, was steroid, topical mesalamine. Jan 2019, first relapse, IV started IV steroid. April 2021, second relapse, topa, started topa, then they developed the tubercular effusion, topa induced, biological induced, then again developed the topacenib induced hepatitis and topa discontinued. On July 2024, he developed the cytomegalovirus colitis, started IV ganciclovir, then shifted to the oral valganciclovir, and patient is well. Okay. The patient, this conclusion, point to be considered regularly, progression of the disease, CME infection, postdiffically infection, adherence of the patient to the therapy, control of rectal inflammation, dose optimization, and colorectal cancer screening after 8 to 10 years is a disease durations. So, thank you.
It was a nice presentation by you. What is the, after how much time you should repeat the colonoscopy, check colonoscopy in such patients? Those who are now controlled, they are in remission.
Yes, sir. Initially, if the patient diagnosed ulcerative colitis and initially we started a treatment, the remission can occur after the 4 to 6 weeks. Then after every 6 months, first initially for the 1 year, 6 months, initially every 6 months, then annually for the 1 to 2 years. We have to check the colon. And patients with cytomegalovirus, after the therapy of the 6 week, we have to check the colonoscopy, whether it is resolved or not.
Yeah. Any question from audience?
It was a very exhaustive but very comprehensive presentation. I compliment you for that. And all these scenarios related to ulcerative colitis were discussed. Just want to add few things that majority of the times in clinical practice when the patient comes with the exacerbation of ulcerative colitis, either there are two important factors. One is non-adherence to treatment and the second is NSAIDs in the clinical practice. Apart from that, Clostridium difficile infection, CMV and other things are there. But common in clinical practice are these two, NSAIDs and non-adherence to treatment. So in all our patients' prescription, we write down that no NSAIDs and treatment for lifelong. That's an important message. The second thing is, earlier when the patient was not responding, we used to, severe acute ulcerative colitis, there were only two options like IV steroids, if not responding. Cyclosporine was earlier option. Then the biologics came. But now there are trials of tofacitinib has been suggested, and it's a cheaper drug with response to the extent of 60 to 70%. There are two trials, 10 milligrams TID as you said, and in another trial 10 milligram BD was given, and they have found response to the tune of 60%. You also discussed the indications of azathioprine very well. So it was a very good lecture. Thank you.
Thank you, sir.
Any other questions from the audience?